Hello everyone, my name is Mariafernanda Graulau and thank you for watching this presentation. Today, I will be discussing weighing the outcomes, the problem, and making the policy decision by addressing one of the most critical public health challenges facing West Virginia, substance use disorder and overdose deaths, and the policy decision I believe offers the most effective and evidence-based solution. Substance use disorder, particularly opium use disorder, has reached crisis levels in West Virginia. The state continues to experience some of the highest overdose mortality rates in the nation. In 2022 alone, more than 1,300 West Virginians died from drug overdoses, while rural males aged 25 to 44 remain the most affected groups. Women and older adults are increasingly impacted due to prescription misuse, fentanyl exposure, and methamphetamine use. Socioeconomic factors such as poverty, unemployment, and limited access to healthcare worsens this crisis, especially in counties like Cabell, Kanawha, and Raleigh. This problem is not isolated to individuals. It reflects systemic failures in access to care, providers' availability, and policy support. Addressing opium use disorders in West Virginia requires system-level solutions, not short-term fixes. For this reason, three potential solutions were considered. 1. Medication-assisted treatment or MAT. 2. Harm reduction programs. And 3. Expansions of telehealth services. While all three interventions are important and complementary, I have chosen to support the expansion of medication-assisted treatment, MAT. Medication-assisted treatment combines FDA-approved medications, such as methadone, buprenorphine, and naltrexone, with counseling and behavioral therapies. Extensive research demonstrates that MAT reduces opium cravings, decreases illicit opium use, improves treatment retention, and significantly lowers the risk of overdose and deaths. Unlike abstinence-only approaches, MAT treats opium use disorders as a chronic medical condition, similar to diabetes and hypertension. I chose MAT expansions as the preferred policy because it directly addresses the biological, psychological, and behavioral components of opium use disorders. Evidence consistently shown that MAT is more effective than counseling alone and is associated with improved long-term recovery outcomes. National organizations, including SAMHSA and the American Society of Addiction Medicine, strongly endorse MAT as the global standard for opium use disorder treatment. The first reason I chose this policy is its proven effectiveness. MAT has been shown to reduce mortality by more than 50% among individuals with opium use disorders. In a state like West Virginia, where overdose deaths remains alarmingly high, policies that save lives must be prioritized. MAT does not merely reduce drug use. It stabilizes patients, improves quality of life, and allows individuals to engage in employment, family roles, and community participation. The second reason is accessibility. MAT can be integrated into primary care, community health centers, and rural clinics. This is especially important in West Virginia, where specialty addiction services are limited and transportation barriers are common. Bringing MAT into primary care settings allows patients to receive comprehensive care close to home, reducing stigma and improving continuity of care. Third, MAT is cost-effective. While upfront investments are required for training, medications, and infrastructure, the long-term savings are substantial. MAT reduces emergency department visits, hospitalizations, incarceration rates, and child welfare involvement. From a public health and economic perspective, MAT represents a sustainable investment rather than a recruiting cost. Now, I would like to discuss why MAT expansion is the best choice for healthcare clinicians. Healthcare providers are often on the front lines of the opioid crisis, yet many feel unprepared or unsupported in treating substance use disorders. MAT empowers clinicians with an evidence-based tool that provides measurable outcomes. Providers who offer MAT report improved patient engagements, fewer relapses, and strong therapeutic relationships. For clinicians, MAT allows them to treat opioid use disorders using the same principles as other chronic conditions, through medication management, monitoring, and follow-up care. This approach aligns with clinical training and reduces the frustration providers often experience when patients cycle through a relapse without effective treatment. That said, barriers do exist. Some providers lack training in MAT, while others express ethical concerns about replacing one drug with another. Additionally, administrative burdens such as waiver requirements and documentation can discourage participation. Counseling requirements can also be intensive in already busy practices. However, policy-driven MAT expansions directly addresses these challenges, incentivizing training, reducing regulatory barriers, and providing institutional support can increase providers' participation. When clinicians receive adequate education and administrative support, many become strong advocates for MAT because they see its life-saving impact firsthand. In regions like West Virginia, providers' buy-in is essential. Expanding MAT without clinician engagement is not possible. Policies that support providers through funding, education, and reduce administrative burdens are critical for increasing access to treatment, especially in underserved rural communities. Next, I want to focus on what I believe is the key selling point of prioritizing MAT expansions in advocacy and health policy development. The strongest selling point of MAT is simple but powerful. It saves lives. At a time when overdose deaths continues to rise, MAT is one of the few interventions proven to reduce mortality. This outcome alone establishes MAT expansion as a moral, clinical, and public health imperative. Policymakers, healthcare leaders, and advocacy groups can rally around a solution that produces clear, measurable results. Another selling point is that MAT reduces the stigma by reframing opioid use disorders as a treatable medication condition. Policies that normalize MAT in healthcare settings send a message that addiction deserves the same level of care and compassion as any other illness. This shift is in perspective benefits patients, providers, and communities. MAT expansion also aligns with health equity goals. Rural residents, low-income populations, and marginalized communities are disproportionately affected by opioid use disorder. Policies that fund rural MAT programs, expand provider training, and integrate services into primary care help close long-standing gaps in access to treatment. From a policy perspective, MAT expansion is practical and scalable. Unlike some interventions that require entire new systems, MAT builds on existing healthcare infrastructures with appropriate fundings and regulatory support. MAT can be rapidly expanded across the state. Finally, I would like to address policy considerations and implementations. Effective implementations of MAT policy requires ongoing monitoring and evaluation. Cost-effectiveness analysis ensures the funding is used responsibly and sustainably. Tracking patient engagement, retention, and outcomes help identify gaps and improve program performances. Provider education must be continuous. As best practices evolve, clinicians need updated training to deliver MAT safely and effectively. Equity must remain a priority to ensure rural and underserved populations are not excluded. Legislative support is also critical. Without stable funding and regulatory backing, even the most effective policies cannot succeed in the long run. Policymakers must remain committed to sustaining MAT programs and adapting them in response to emerging evidence and community needs. In conclusion, after weighing the prom, evaluating the outcomes, and considering feasibility, I will support the expansion of medication-assisted treatment. It is evidence-based, clinician-supported, most effective, and most importantly, life-saving. By expanding MAT in West Virginia, we can reduce overdose deaths, support healthcare providers, and move towards a more compassionate and effective response to substance use disorder. Thank you for your time and attention. I hope this presentation was informative. I am happy to answer any questions at this time.